Good afternoon. I want to welcome you to UCSF Family Community Medicine Grand Rounds. We have a very special presentation today that I'm excited about. The title is Afghan Clinic, Barriers to Health for Afghan Refugees and How We Can Address Them. I'm glad you can join us today. As a reminder, this session, like all other Grand Round sessions for family medicine, are recorded, and hopefully you all press the recording button so that you can join us. If you want to see this session again, or you missed part of it, or you'd like to see the recordings from prior session, as just a reminder, after these sessions are recorded, you can go ahead and take a look at them on our website. We have all the prior ones and they're really fantastic. To get us started today, we would not have been able to make this session happen without Roy and Ben, our great team of support. So I want to just thank them in advance. And as a reminder for those of you who haven't joined us before for FCM Grand Rounds, please use the Q&A section for questions. We have some fantastic presenters today who are looking forward to hearing your thoughts and ideas. So go ahead and just type them in. You can also fill out an evaluation for this Grand Rounds or any previous ones that we'll be sending out electronically if you want to fill that out during the session to give suggestions for us for future Grand Rounds or for our presenters. So with no further ado, I want to welcome our very exciting presenters. We have a really wonderful presentation today from Nazineen Kandahari, who is currently a UCSF medical student, and Nilufar Kayahani. I'm sorry, make sure I pronounced that correctly, who put together a presentation on Afghan health. The last 4 decades of turmoil in Afghanistan are responsible for one of the worst episodes of forced displacement in world history. Nearly 6 million Afghans have been forcibly displaced from their homes, leaving them at the risk of poor health. Afghan Clinic is a public health initiative by and for Afghan refugees. In this talk, Nilufar and Nazineen will discuss the findings from interviews with Afghan refugee women and community organizers who serve them. They'll conclude with the recommendations on serving Afghan refugee patients and mitigating their barriers to health and healthcare. Just a word about our presenters. Nazineen is a rising 4th-year student in the UCSF Med School and Prime. She's also in the JMP. Nazineen is herself an Afghan refugee. From a young age, she committed herself to promoting her people's agency. Through community service, research, and public health intervention work, Nazineen has established herself as a trusted leader within the refugee community. She's passionate about health equity and community engagement. She's currently the PI of a community-based health project for Afghan refugees and the founder of a student-led health education intervention called Afghan Clinic, which we're going to hear more about today. She completed her Master's of Science at UC Berkeley and did her work on exploring the sexual health needs of Arab immigrant youth. Nazineen was named the student who rocked public health in 2021, I love that, by the Journal of Public Health Management and Practice, and is a UC Berkeley School of Law Human Rights Center Fellow, as well as an Albert Schweitzer Fellow. Presenting with her today is her sister, Nilufar Kayahani. Nilufar is an undergraduate student studying public health at UC Berkeley. She's committed to resolving health inequities, particularly those experienced by refugees. She's initiated multiple community-based participatory research projects with historically marginalized populations while at Berkeley. She investigated the impacts of COVID on first-generation low-income students and supported Nazineen in founding the Afghan Clinic. Nilufar is currently a research intern at the Gladstone Institute at UCSF, and she is a pre-medicine student who is passionate about public health. I am very excited to welcome you both, and thank you for your presentation today.
Thank you.
Great. Can we all see?
Yep, it looks great. Awesome. Good afternoon, everyone. My name is Nazineen Kandahari.
And my name is Nilufar Kayahani.
And we are honored to have this opportunity to present to you all today. Thank you, Dr. Benner, for your warm introduction, and thank you all for being here. We're presenting to you on Afghan Clinic, a public health intervention created by and for Afghan refugees. This project is the coming together of my privileged professional American world with my marginalized personal Afghan world, and it is near and dear to my heart.
Before we get started, some housekeeping. First, we have no disclosures today. And second, these are the things that we will cover today. We will discuss how we developed a community-based participatory research project for a marginalized community, such as Afghan refugee women. We're going to examine some of the sexual and reproductive health experiences of Afghan refugee women living in the United States. And we will explain how Afghan immigrants are at risk of worse health in the United States and the ways that we can support them.
Let's begin where it really all started. My family is from Afghanistan. We were forced to leave by the Soviet invasion and Taliban and sought asylum in the United States in 1998 when I was just 3 years old. But how could I do my job right when we came from a country that rarely had resources to offer healthcare? How could I convince my parents to go to a doctor if I hadn't yet figured out how to file their taxes, figured out our legal status, our livelihoods? I couldn't advocate for better quality of care if we didn't even know when or how to go to a doctor. I needed to teach my family about having agency and what health and happiness feel like for the first time. I needed to teach my family that being immersed in a complicated and inaccessible healthcare system in the America they used to dream of is just a new flavor of violence. I needed to teach my family that escaping death, rape, and prison is not an end goal, that good enough is not good enough. And this experience is not unique to our family. We are not alone.
The last 4 decades of turmoil in Afghanistan are responsible for one of the worst episodes of forced displacement in world history. There are nearly 6 million Afghans who have been forcibly displaced from their homes. That makes Afghans the 3rd largest displaced population in the world. And in light of the deteriorating situation, these numbers just continue to rise. Over 500,000 people have been displaced in 2021 alone, and women and girls make up the majority of those displaced. We also know that refugees suffer a high burden of acute and chronic mental health problems, especially depression and PTSD, chronic and physical health problems because they have been victims of torture and violence, treatable and infectious diseases because of lack of access to regular health care, malnutrition and anemia, and gaps in maternal and obstetric care, which increase the risk of maternal and neonatal morbidity and mortality. And yet, despite this high burden of disease, access to healthcare for forcibly displaced immigrants is both variable and limited in host countries. First, there are legal barriers to accessing healthcare. For example, asylum seekers can only seek emergency healthcare services. Second, while most host countries offer some sort of medical screening upon arrival for refugees, not all do. And when the health screening is offered, the content is variable and the quality is questionable. Mental and reproductive health are often overlooked. There are also practical barriers to accessing healthcare. Forcibly displaced immigrants often have inadequate information about available services, insufficient financial means, restricted access to transportation, culturally insensitive care, and inadequate provision of interpreters. As a result, the health needs of forcibly displaced immigrants is likely not being met. And though we have all these reasons to believe that Afghan immigrants have unmet health and healthcare access needs, there is a scarcity of academic research and public health interventions that center them.
Thus, we set out to address exactly that. We chose to focus our sample on women because we know that Afghan women are particularly at risk for worse health and healthcare access for a number of reasons. For example, women in Afghanistan are unable to leave their homes without a male relative for any reason under the religious law. Women in Afghanistan are unable to equally access education. Their secondary school completion rate is 40%. And the literacy rate is 17. They are unable to equally access the workforce. Only 16% of women in Afghanistan work outside of the home. And women are subject to additional healthcare barriers. For example, health workers in Afghanistan refuse to provide contraceptives to unmarried women because women who have sex outside of marriage can be punished by law by being imprisoned, lashed in public, or worse. And that was before the current Taliban regime.
and their sexual and reproductive health is especially suffering. The maternal mortality ratio in Afghanistan is one of the highest in the world. One woman dies every 20 minutes from a pregnancy-related cause in Afghanistan. We know that there is a correlation between improving contraceptive prevalence and reducing maternal mortality. And yet, there is only a contraceptive prevalence rate of 14% among married women under the age of 49 in Afghanistan. And we don't even know what the rate is among Afghan women living in the United States. Therefore, it is critical to both better understand the sexual and reproductive health needs of Afghan immigrant women and to increase the prevalence of contraceptive use among them.
Therefore, we conducted a qualitative study exploring the health and healthcare access needs of Afghan immigrant women. Because we know how stigmatized sexual and reproductive health is in particular, we also set out to explore that. Our work is rooted in the cultural humility framework described by Drs. Melanie Turvalon and Jan Murray Garcia as a lifelong process of learning, of centering others, of learning about them from them, and of mitigating power imbalances. For example, though my parents raised me proudly immersed in Afghan values and traditions, I would never claim to know what it means to be Afghan. I will never know because there is no one way. Nilüfer is my own sister, and yet I can't assume her identity and lived experience as an Afghan are the same as mine. By being a refugee, I have learned to appreciate that people have different values and practices and ways of identifying themselves, and that it is my job to create a safe environment for everyone to express themselves. So I shared that positionality with the Afghan women when I interviewed them as well, that I was raised in an Afghan culture that valued sexual purity and shamed sexuality, and that I grew up in America, where I learned about those very topics in public school, and that as I figure out where I stand, I want to learn where other Afghan women stand and how I can best support them. We also used the community-based participatory research framework, meaning we included the expertise of Afghan refugee women in every step of creating and conducting this project. In the first stage, we established partnerships with community-based organizations that serve Afghan immigrants in the San Francisco Bay Area. This included refugee resettlement organizations, refugee health clinics, mosques, and more. We sought their input and guidance to create our recruitment materials, our interview guides, and our entire project approach before applying for institutional review board approval. We also worked closely with Afghan refugee women who could speak, read, and write both English and Dari, which is the official language of Afghanistan and what is spoken by the majority. With them, we translated and back-translated our project materials and pilot tested everything to assure that it was suitable for Afghan immigrant women, taking into account literacy and education levels, cultural norms, particularly when it came to discussing the sensitive topics of sexual and reproductive health.
Then we began data collection. We conducted semi-structured interviews with both key informants and Afghan immigrant women. Key informants were defined as people who regularly serve Afghan people in any health promoting context. We included them to cover any health issues that Afghan women experience that they may not know or be able to express. We recruited Afghan immigrant women with the support of our community partners who disseminated our project flyers digitally and used our script to make verbal announcements to their clients by phone or on Zoom calls. We also disseminated our recruitment flyers on social media. Anyone who was interested in participating contacted the research team. And we then screened them for eligibility criteria, which included that they were not born in the United States, over the age of 18, and able to speak English or Dari. All of our interviews with Afghan women were conducted over the phone and in the Dari language, and Afghan immigrant participants were compensated with gift cards for their time. Our research team wrote analytic memos after each interview and discussed general findings. And until we met data saturation, we sent our community partners regular reminders to continue recruiting. And finally, we use an iterative coding process and thematic analysis approach to analyze the data. Our final sample consisted of 24 Afghan immigrant women and 15 key informants. And among the Afghan women participants, the mean age was 33, and the mean years of having lived in the United States was about 5.5. And in terms of education, 16% did not complete any formal schooling, but 45% had completed part or all of high school. Their reasons for stopping school ranged and demonstrate a human rights issue in and of itself. When asked why they stopped or didn't start school, they said, "Don't ask me that question. I will cry, because Afghanistan didn't let little girls go to school. Because I was growing up in an era of the worst war in Afghanistan. Because the opportunity was not there. Because I got married, then I came here. I wanted to get my PhD. I studied English for it too. I wanted to continue." Now moving on to our qualitative data, we're going to share some quotes that represent some of the salient themes. Let's begin with what healthcare access issues these women had.
The first set of barriers pertain to the use of medical interpreters. This is a 30-year-old Afghan woman who immigrated 5 years ago. She said, "I don't understand Farsi. Whenever they'd call for an interpreter, they were mostly Farsi speaking. Sometimes you'd get one who was rude. If you asked them to repeat what they said, they'd say, 'Lady, our languages are not that different for you to ask this many questions.'" This key informant is a health psychologist at a federally qualified health center and an Afghan refugee herself. She said, "There's a lot of fear for judgment, fear of being founded by other Afghans or by interpreters. We as providers assume there's already a connection, a sense of safety. But I just actually ask the patient, 'Hey, do you feel comfortable with a male interpreter or a female interpreter? Is a dialect of Farsi okay for you, or do you speak Dari and you have no idea what they're saying?" From our interviews, we found the following issues with interpretation services. First, we found that not all of our participants were offered medical interpretation services consistently. Second, most healthcare providers assumed Afghan refugees spoke Farsi, which is a language most commonly spoken in the country of Iran. While Farsi is similar to Dari, it is not the same. We cannot use Farsi interpreters just because we assume it's close enough. It can be harmful to do so because it gives providers the false belief that patients understand at least some of what is being said. Third, we found Afghan refugee patients sometimes experience discomfort sharing personal information with healthcare providers and interpreters, for fear that their personal information would not stay private. And fourth, our participants reported experiencing unprofessional standards of care from Farsi-speaking interpreters. Interpreters insulted them or expressed frustration towards them for not understanding Farsi. This dynamic between Iranian Farsi-speaking interpreters and Afghan Dari-speaking refugees might be reflective of the historical discrimination and violence experienced by the Afghan people seeking refuge in Iran. Another issue we identified was getting refugees established with continuity of care. Because it is not mandated by the government that we support refugees in their transition to the United States in this way, there's no system set up to facilitate it. There's no accountability that we get refugees established in regular and integrated care. This is a social worker from an Afghan community organization who said that mandatory physical from the resettlement agencies could be a perfect place to get people connected to all their medical needs, including dental. But it's not done, and it's not on their list of federally mandated things, so they don't do it. This physician at a refugee clinic says, you really just have one visit to try to get people inside. And I would say that that has varying degrees of success. Another common barrier was a lack of familiarity with the healthcare system in the US and how it contrasted to their experience in Afghanistan. This participant is an Afghan woman who gives insight into what a new immigrant experiences when immersed in the health system here. She said, there in Afghanistan, when you'd go to the doctor, they would very quickly give you a medication, or if you needed a surgery, they would give you the surgery right away. Here, until it's your turn for your appointment, or until your pain lessens or improves, these things particularly bother me and will likely bother other Afghan women too. Here we see how refugees lack an orientation to their new healthcare institution, to what to expect from and how to be in the healthcare setting, whether or not they can advocate for themselves, when and how to seek care, who they can trust and how much, and what their rights are. And inevitably, they wonder why they are being treated as such, and if others are being treated the same. We found Afghan refugees reported that mental health concerns were a common issue among their community, and often assumed it was because of their forced displacement. When asked about their mental health issues, this 27-year-old Afghan woman who immigrated 6 years ago said, "Because there's a lot of problems and they aren't comfortable in their lives here. The cause of their depression is being far from family." And this 51-year-old Afghan woman who immigrated 6 years ago said, "I have been bothered by stress and depression and anxiety. I've been really upset by these. We're also in really bad living circumstances, the place where housing was given to us." These people don't just face the trauma of the violence that forced them to leave their countries, but they left their country because they had to. They were uprooted from their lives and they didn't choose to be. They didn't choose to leave. Our key informants explained how mental health issues among Afghan immigrants often present somatically, that they rarely have patients who use the language of mental health. Thus, we must look for psychosomatic presentations of common psychiatric ailments. This is a physician at a refugee clinic who explained, for example, you're never going to meet an Afghan refugee who will complain of anhedonia or any of the other cardinal symptoms of depression. What they're going to complain about is a headache. That's one of the core symptoms of depression in this particular cultural group. And this Afghan woman demonstrated that when she said, "Some part of my body always has a feeling of pain. Sometimes I think it is my heart. Sometimes I think it is my flank. Sometimes I think it is my hips. I have pain. I feel it. I don't know if it's pain or if it's depression. This results in lacking the desire to live one's life."
Next, we like to focus on some of our findings related to Afghan women's experiences with sex, pregnancy, and family planning.
We found that it can be difficult for women to transition from Afghanistan, a country that placed many sociocultural restrictions on women, to the United States, which suddenly, in comparison, does not. This Afghan health psychologist says, "They're already stretched so thin just based on their immigration history and the trauma that they've experienced. So I see that as a strife for Afghan women to actually advocate for themselves and ask, I think I need some birth control. How do I sneak this around my husband?" So we have to really do strategic planning and know that this is the patient's wish and that they can consent to their own care and giving them that right, but not sort of titrate that. You can't just outright tell an Afghan woman, it's your right, it's your body, you don't have to have a child if you don't want one. I did that once and I learned the hard way. That is not how you work with Afghans. And this doctor, who works at a refugee health clinic, highlights a different way in which those sociocultural restrictions in Afghanistan present themselves when these women transition to the US. He said, "If you're taking any history from a female patient, you're going to have to know when their last period was. Having to ask a little brother, to ask an older sister, that's not ideal. If she has a gynecologic complaint or healthcare need, if her only access to the outside world is through her brother or husband or whatever, it becomes more difficult, an extra step. I have the impression that there are culturally specific barriers to access to healthcare." This 29-year-old Afghan woman who immigrated 6 years ago said, "One day I told my husband, I won't use you as an interpreter anymore. I'll get my own. Then he said, then you won't tell me what the doctor said. My husband just told me there's this option and it's the better one, and I never got to see it." For many of our participants, their husbands often served as their interpreters at medical appointments. This is because their husbands often can speak English, but also because their husbands assume the role of decision-making for their wives. This is what the health psychologist was referring to, that autonomy in the Afghan culture is not assumed for women. This woman tried to facilitate autonomy for herself by telling her husband she'd get an interpreter, but he didn't allow for it because he didn't want her to potentially withhold information about her health decisions from him. And as a result, she got an IUD placed without even deciding herself or truly knowing what it even was. From our interviews, we learned that facilitating access to sexual and reproductive health care for Afghan women is multifaceted. We must first acknowledge that independence and freedom have not been birthrights for Afghan women the way they have been for most white Americans. We must recognize that Afghan refugee women are coming from a circumstance in which their access to the world is through the men in their family. We must seek to understand where Afghan women are currently at with the idea of autonomy, that they have experienced trauma and oppression, and that is what they know to be true. We must gain their trust, then gradually teach Afghan women about the concepts of autonomy and privacy. We must help them to feel comfortable in their autonomy. We must approach these women with care and compassion for where they are at culturally and acknowledge that their cultural system has been jarringly disrupted. We must, again, use interpretation services all the time and not default to family members for interpreting. But as we already noted, the use of appropriate interpretation services was a rare occurrence in our sample. Many of our participants also received substandard reproductive health care from providers here. That same 29-year-old woman shared her story. She said, "I had told the doctor that I don't want any more kids until I learned parenthood a little bit. The doctor didn't pay attention to me at all. I told them twice to give me a medication that will prevent me from getting pregnant again. It did not happen, and eventually 2 or 3 months later, I got pregnant. After I delivered my daughter, I had an IUD installed. I never saw it, and I used to worry, what was that thing? What will it do? My doctor didn't teach me." Due to the lack of education Afghan women had about sexual health and family planning, most of them had learned about these concepts through experience. As a result of not being taught about sex, even that it exists, let alone what is considered healthy, some of our participants reported traumatic first sexual experiences. This 30-year-old woman said, "No one told me about the wedding night. I was completely shocked. I was scared. I cried a lot too. And I wouldn't let my husband even get near me. He would laugh, saying, 'Well, this is just how it is.' And I, truthfully, was overly terrified. Overly. This woman describes the sociocultural experience with abortion in Afghanistan. In Afghanistan, if you get pregnant and you absolutely do not want to be pregnant, you do not have the right to abort that fetus because they say that is a sin. And if you found a nurse, it's very hidden and for a very high price. Even then, they won't do it in a hospital or a clinic. It's usually done in someone's home. Which is reaffirmed by this 40-year-old woman who said, "In Afghanistan, it's a problem because you cannot do anything about an unwanted pregnancy. When you're pregnant, you have to deliver it. For birth control, people mostly use the IUD, but it's mostly only people who have an education. The majority of people don't know these things."
And these last bits of findings pertain to Afghan women's experiences with and knowledge about menstruation.
In our interviews, we found that the topic of menstruation was associated with much embarrassment and shame. Mothers did not necessarily feel comfortable teaching their daughters, not just for lack of knowledge about the topic, but for lack of acceptance about the topic. This 29-year-old Afghan woman who immigrated 6 years ago shared, "When you said period, a lot of girls would feel embarrassed or couldn't ask questions. Even my khwar khwanda, which is the Dari equivalent of saying my girlfriends." This 23-year-old Afghan woman who immigrated 3 years ago said, "Afghan women, even to this day, some of them don't even talk about the menstrual cycle or about like stuff at home, even mothers to daughters. We don't really sit together to, share our wisdom on like what to do and what not to do. I've met young girls who feel embarrassed to ask their mothers or approach them with issues about their menstruation." We also found that sources of information about menstruation were extremely limited. If mothers felt able and comfortable to teach their daughters, then they were not necessarily able to teach their daughters. They were able to teach their daughters about their experiences, but not necessarily more. Our participants said that they were not taught about why they got periods or how to care for themselves during their periods, or what is considered abnormal when it comes to menstruating. This participant said, When people don't know something, honestly, it's so hard. In those times in Afghanistan, there weren't even phones. At least now people see things from their phones and the internet. Those times, there wasn't anything and nobody knew anything. And it's important to note that she refers to those times in Afghanistan, but she had only immigrated 6 years ago. So these are problems that our current patient population is living with. We also found that a number of women reported traumatic experiences with menarche. Oftentimes, this was due to the cultural shame and embarrassment that we've already demonstrated. But it was also due to the fear associated with the general topic of sexual and reproductive health. Knowing that postcoital bleeding is used as an indication of one's virginity in Afghanistan, and that women who have extramarital sex are punished, caused for fear of similar consequences when girls experienced menstrual bleeding. And women carried that trauma with them long term. This 30-year-old woman said, "For about 1 year after menarche, I was scared to tell anyone this thing was happening to me. And every time that it happened, I would cry excessively, asking, 'Why, God, is this happening to me? Who should I tell? How do I tell them? What if they hurt me? What if they kill me?' I was scared. My thighs would chafe. I would cry internally because I couldn't find a way. I was crying internally, screaming even, but by tongue, by eyes, by face, I couldn't tell anyone anything. That I couldn't even walk because my legs, between my legs, had worn away. The things I'd used for my period were too big because I was afraid. I needed to put something big so that my clothes wouldn't get soiled. And I would get it wet. After washing it clean, I'd put it back wet and use it like that. I think my chronic back pain came about because of this." This is a different 30-year-old woman who shared, "Even though my mother is a progressive woman, she went to school. Before I got my period, my mother had told me, 'You are not supposed to bleed there. If you bleed, you will die.' She was thinking something shouldn't impact me there, or that I don't engage in anything else, or that there isn't anything else going on. That's why. So the first time I got my period, oh, the world went dark on me in a different kind of way. I'm going to die now, I'd think, every time I'd go to the bathroom and clean it with toilet paper and cry."
And though we're still in the process of analyzing and publishing the findings of our needs assessment, we have already begun to address some of the issues we encountered. With the continued support of our growing community of immigrants, we founded Afghan Clinic. Our mission is to create novel health education materials and public health interventions, and to conduct research that will promote the health of Afghan immigrants. We create our health education materials with healthcare professionals and Afghan immigrants who help us to translate and pilot test everything. We disseminate that information in the format of an online community forum and webinar where we provide a short lecture grounded in a basic overview of relevant biology, but leave the majority of our time for an interactive dialogue and Q&A with the community. These have helped to facilitate conversations among the community about health. And we've taken advantage of the online world. By having virtual gatherings and videos, our material is available to people at their convenience, is accessed by people across the globe, and mitigates practical barriers such as transportation or whether or not their husbands will let them leave the home to learn.
Today, we shared a bit about what we have been doing. Our work is a growing and iterative process. As for what you can do as an individual, we have a number of recommendations. First is to ground yourself in cultural humility. Engage in the self-reflection process. Commit to the journey of becoming a lifelong learner and critiquing health disparities. Health disparities don't just passively exist. They exist because they were made to exist. They exist because we let them continue to exist. And it can all be different. We can make systems that don't marginalize specific people. And we must also teach and promote cultural humility on the institutional level. It should be taught at all medical schools, but also colleges at every level of education, not just for people working in clinical settings. We also need to radically change who becomes a doctor. To have seen the need for this work and to have done it, I needed to be a seasoned qualitative researcher, yes, but that was not enough. For these participants to share about their most traumatic life experiences, I needed to create a space where they felt safe doing so. I needed to earn their trust. I needed the cultural humility and the lived experience to connect with them, and no other researcher could have. And we need more doctors like that. Doctors from communities where these health disparities exist. They have the knowledge, they have intimately experienced the discrimination, and they have the strengths too. They have the resilience and creativity to find a way. And we need to support them in getting to and through having a fruitful career as a physician. I hope from our presentation, you all have gained new perspective and insight into how Afghan refugees are subject to health inequities. So I urge you to use your skills to work with marginalized communities, people from different races, ethnicities, genders, sexual orientations, and income levels, and to find solutions for their worst health outcomes. But when you do so as an ally. Find the Black and Brown people who are already doing this work, support them, credit them, pay them, but do not colonize health disparities research. I urge you to read this article on Stat News and this rich poem published recently in the International Journal of Epidemiology. They highlight the gold rush mentality where researchers with little or no background in health equity research, often white and already well-funded, are rushing in to scoop up grants and publish papers on the topic because of their newfound awareness. While this can be well-meaning, it can also be opportunistic. Do not build on the work of Black and Brown researchers without citing them or offering to include them on grants or as co-authors. They have built the foundation of this discipline. And even academic journals who claim they don't look at author demographics, they must know that taking a neutral, colorblind stance only perpetuates longstanding inequities. When it comes to interpretation services, please remember that Dari is not Farsi, and the use of Farsi interpreters for Dari-speaking patients can be harmful. So first, we recommend that you have Dari interpreters at your institution. We recommend that you always offer interpreters to patients who have immigrated or indicated they primarily speak another language, that you always ask patients what language they prefer instead of assuming, and that you start every visit with an interpreter and only let family members interpret after a patient has indicated they understood their options and consented. We recommend increasing appointment times whenever possible for these patients to mitigate any potential pressure on you to rush through proper informed consent and care provision practices. And we recommend that you create and use methods of assessing and improving patient experiences with interpretation services. We must be able to identify instances when our patients are made to feel uncomfortable by their services and prevent that from happening again. We urge you to follow the tenets of patient-centered care. Foster healing relationships with patients. Respond to their emotions and manage uncertainties they have. Ask for what they know and what they may not know. Involve them in every step of the process so you can ensure that they've made an informed decision best tailored to their needs and values. Acknowledge your positionality as a healthcare provider. Start every visit by setting expectations. Help your patient to understand what's going to happen, what they'd need a separate visit for, and how their goals can be met. Help to establish a sense of safety. Discuss confidentiality and how you can help them to feel comfortable sharing vulnerable personal details about their health. Exchange information with them. We recommend communicating education content to no higher than an American 5th grade level and to avoid clinical language. We recommend you ask patients how they would like to receive information. Before providing written information, make sure they know how to read, and get creative with how you provide them with information. Some of the refugee clinic doctors we work with found success drawing out diagnoses, writing instructions directly onto the pill bottles, putting pictures on the pictures and screenshots in the after visit summary. We also recommend having patients teach back to you what they learned, so you can clarify any misunderstandings. For example, you might ask, please tell me how you plan on taking your thyroid pills this upcoming week. And engage patients in the decisions that are made. As healthcare providers, What are we doing if we're not even getting consent before inserting an IUD? We need to have all patients understand the risks, benefits, and alternatives of their health decisions.
We also encourage you to utilize the tenets of trauma-informed care. Practice a strengths-based approach. Recognize that this community is resilient and focus on their growth. Congratulate them on their health progress and lead questions about their history with their strengths. For example, you could ask, tell me about yourself. What things are you good at? We also encourage you to create an immigrant-friendly environment. Familiarize yourself with the current legal requirements for refugees and immigrants. Familiarize yourself with the community organizations they might be or could be working with. Ask for permission when you might discuss topics that are difficult. And offer to educate them on the healthcare system. For example, when to go to the urgent care versus a primary care, where to pick up their medications, and so on. Lastly, consider trauma and its physical manifestations when thinking about differential diagnoses. For example, consider how it might manifest in behavioral responses in children. But also consider it when thinking about treating a patient. When giving treatment options, educate the patient and let them choose what they are most comfortable with. And before sharing specific considerations you might make for Afghan refugee patients based on culture, we reiterate the importance of cultural humility. We urge you to be curious, to be welcoming, and to learn from them. This is not a guide on how to treat all Afghans, but merely a place to start in some common issue areas. First, we want to highlight the gender norms. In general, to promote comfort, consider offering female practitioners for female patients. And if a male practitioner must work with the female patient, inform the patient early and explain what will and will not happen, and ask how they'd feel most comfortable proceeding. For example, if they would feel more comfortable if the physical exam is chaperoned by a family member. When taking patient histories, ask them about their schooling. Clarify where patients have gone to school. We've had patients who've indicated, for example, that they completed the 6th grade, but upon clarification, they explained that their school consisted of going to the mosque and learning the Quran. And lastly, Afghan patients may not know their exact birthdays. This is worth clarifying, particularly when establishing care, as it can affect, for example, when they're eligible to start screening for certain diseases.
With that, we go into acknowledgements. First, I want to thank the Afghan women for their immense bravery, resilience, and unwavering hope for better. I am forever inspired by them. And I thank the Afghan woman who made me, my mother, for building this project with me, for teaching me that kindness is always the answer, for quietly leaving a bowl of cut fruit at my door while I study. My success is yours, Mom. I thank my mentor, Dr. Susan Lee Ivey, for her unparalleled and unwavering support. I thank Dr. Zareen Noor and Zerluna Rahim, my fellow Afghan immigrants and mentors who have been critical in my work and well-being. And I thank Dr. Nick Nelson for believing in me from the start when it was just an idea and helping me to nurture it. And I thank the Albert Schweitzer Fellowship, the UC Berkeley Human Rights Center, and Center for Race and Gender for funding our work.
We thank our partners in our team, which is made up of students who are either Afghan refugees or the children of Afghan refugees. This work would not have been possible without them. Please visit afghanclinic.com for more information.
And we'll end here where you can find our contact information if you have any questions, comments, or want to collaborate. And I'd like to share this poem that beautifully encompasses our work at Afghan Clinic. It says, "Go to the people, live with them, learn from them, love them. Start with what they know, build with what they have. But with the best of leaders, when the work is done, the task accomplished, the people will say, we have done this ourselves." Thank you.
Thank you. That was a fantastic and very provocative presentation, giving us a lot of information to think about. I really appreciate your honesty and all the hard work that you've done. Colleen Kiblehan added her thoughts. She said, not a question, really just a fabulous presentation. I learned so much. And then Anshu added, this work is important. Thank you for your continuous effort in it, inspiring. On the topic of cultural humility, how do you balance values of autonomy with meeting Afghan patients, in particular girls and women, where they're at? relatedly, what about your interviews or your clinic was most surprising to you? Sort of great questions. Thank you for asking. Thanks,
Yeah.
Anshu.
Thank you both, Dr. Kiblahan and Anshu, for being here and for your encouragement and support. Anshu, I think you asked a great question. I think that is what the health psychologist and what we tried to highlight in her quote demonstrated, is that, you know, it's hard when you can't just come in outright and try, for someone who hasn't been exposed to the idea of freedom, for example, in the way that we have, or to the idea of autonomy in the ways that we have. It can be pretty jarring to suddenly expect them to adopt it. And I'm not saying to not teach people those, but instead, again, to just meet them where they're at and perhaps take that process a little bit slower and see where they're comfortable. And in terms of what's most surprising in terms of our work, that's a great question I'll think a little bit about. I don't know, Nilüfer, do you want to add anything to what I've currently shared?
I think you have addressed it pretty well so far. I think it wasn't necessarily surprising, but something that was kind of really cool for me to see was that so many Afghan women were kind of hoping that their daughters here in America would have a different shot at sexual and reproductive health education. Multiple of our participants, you know, affirmed that they were excited that they had to sign the consent forms for the puberty talk in 5th grade or the pregnancy talks in high school. And so I think for me, it was a nice takeaway to see. I don't know if you have anything else to add, Naz.
Yeah, no, I was going to add that as well, that women seemed very excited to have a change for the future generations. And in that being here, for example, I would ask them, like, how do you feel about your kids learning about these topics in school? In 5th grade, they learn about puberty. In high school, they learn about sexual education. And most of them were excited and were grateful because they also learned through their daughters or their sons coming home and teaching them.
Yeah, that is really important. I appreciate your pointing that out. Dr. Anthony Sumpkin asked another great question, which is, what do Afghan men know about their wives' sexual issues? And I would actually add to that question a question of my own, and I know that we had talked about it earlier, which is, how does the work that you've done in your own experiences inform your approach to Afghan men? So a couple questions wrapped up together.
Yeah, I can see how, and part of my own learning and how when people see this data, they can see that Afghan men can really pose barriers to the health and healthcare access of Afghan women. I also think they're a great opportunity where we can intervene upon. If they are, you know, if it's going to take a while for us to, you know, if Afghan men are serving the head of household role, for example, and they want to make health decisions for their wives, then the least we can do is make sure that they are fully educated so that they can educate the others within their families. The other thing we can do is also educate them on women's autonomy and hopefully help them to learn that women having autonomy is not a threat to them. And I think, yeah, it would be, for anyone who's trying to do this kind of public health intervention work, it would be a really great idea to get Afghan men involved. Nil, do you have anything to add?
I think that was pretty good. Yeah.
That picks up on a question from another attendee who said, very well done, thank you. Impressed by your content and presentation. If women lack knowledge concerning menstruation and general gyne issues, how much do men know? Is divorce taboo? And also, how do you handle cases when women still want to remain submissive to the men? Thank you again, is what the comment asked.
Yeah. Thank you for this question. I think going in order, sorry, let me find the question again. I think it's a great question. How much do men know? I think sexual health education is not offered in Afghanistan, period. So it doesn't only affect women, it affects everyone in Afghanistan. And so I think everyone can benefit from learning enough information so that they can make the best decisions for themselves. And we can do that in whatever way they're comfortable learning. And so we did not study Afghan men in this particular project, but my assumption would be that it's probably comparable because they also lack formal education on any of these topics. And yes, divorce is very taboo. And in fact, one thing I learned going back to Anshu's question, what's surprising is I've taught myself a little bit about what the laws are in Afghanistan. And a woman is considered to have cheated if she has had sex before marriage. So not even during her current marriage, but having had sex before marriage, that is considered cheating and therefore allows for punishment, whether that's imprisonment or lashing or death. And then how do you handle cases when women still want to remain submissive to men? I think the best we can do is respect what people want and try to educate them on, make sure that that's not their default, that they're not doing that out of lack of knowing, but they're choosing to do that, and then respect their choice. Thank you for that question.
Niloufar, do you want to add anything to that? It was a great response.
I think Naz wrapped it up pretty well. I guess the one thing I might add to the question about is divorce taboo? I mean, it's also on a case-by-case basis. I think in Afghanistan, a lot of perspectives towards it are not great. And as Naz mentioned, like people can get, punished and whatnot. But here in the United States, there's not like a concrete perspective towards it. And so, yeah, that just might be something to add that.
Thank you for adding that. And then Maddie Kane asked a question very related to another question that I have, and I think probably that all of us are wondering. Maddie wrote, "You're all amazing. What are your dreams for this work? One thought, where do you see this fitting into other clinics or policy-based work?" And I would add a question that's on my mind as an educator and probably on many people's minds who are educated in this audience, which is, what do you see as the next steps for the work that you've done once you go ahead in your health-related careers and your medical careers? You both seem like you're off on an incredible trajectory of doing this work, and who's going to take care of the work that you've started, and also where do you see yourselves going with this? So wrapping up a lot of questions all together. Thanks.
Yeah, thank you. And thank you, Maddie, for the question. And again, for your support and encouragement. I think we want to see Afghan Clinic grow and become a sustainable public health organization. And so again, the 3 tenets of what we try to do is promote novel public health interventions that uplift the strengths that already exist within the Afghan community, to promote health education that's tailored to the community, and to continue doing research that will uplift the health of this community. And in fact, the original health idea that started this whole journey is what we call Sofra Salamati. So the Sofra is a spiritual gathering organized by Afghan women, and it's exclusively for Afghan women. And it's really quite a sacred space and a demonstration of one of their many strengths. And it has many health benefits, like that's an area when they can social network, and it promotes spirituality, and all of those have health benefits. And so what we would love to do once COVID permits is to continue those sessions and then supplement them with health education discussions. And long-term, we would love to include more and more communities and make our work even more accessible.
And just to wrap up here, this is really, again, the levels of thought and detail and the layers of work that you put into this is really inspiration, I think, for all of us who practice family medicine, and for those of us who work in education. And you've both been very modest. So can you say just a bit about where you see yourselves going with this work for the future? I'll just speak for myself. I'm curious, and I'd like to hear a little bit about what you see in the future for this for yourselves.
Yeah. Again, I would love to see Afghan Clinic become a sustainable organization, for us to be fully funded and have more people on board growing it with us. I myself am inspired to do work like Dr. Nelson or Dr. Kivlahan, and hopefully one day we'll run my own refugee clinic. I'll manifest that now. And yeah, I think there's plenty of work to be done. So one area that I think I have skills and strength to offer to this community is in research. And to answer Naomi Wartis's question, there's plenty of research that needs to be done. If you search Afghan refugee health on PubMed, you will see there's, like, most of what's on there is from Afghanistan itself, very little about Afghan refugees within the United States. Yeah, and I encourage everyone to get involved.
And Niloufar, do you want to share your thoughts, and then we're going to wrap
Sure.
up. We're going to wrap up soon. Thanks.
Yeah, I think I share a similar sentiment to Naz. I intend on kind of staying with this work and seeing it through, and eventually starting my own journey in medicine and kind of helping out in the ways that I can, and continuing to do this research as well. And I think a lot of our goals with it is keeping it sustainable. So having and establishing our team of Afghan medical students and pre-health students, we can hopefully keep it going for a while.
Thanks to you both. There's a whole series of comments in the chat from Naomi Wartis and Suzanne Barakat and Nick Nelson. Thank you for your incredible work on this project. We're excited to hear you about what you can do with your futures, but also really thank you for elevating our awareness of the unmet needs of this patient population and for the work that you're doing on behalf of your community. So I want to thank you and thank everybody for attending Grand Rounds today. We will invite you back to give another presentation in 5 years, and you can update us on all the great things that you've done. Thank you. Thanks to everyone.
Thank you. Thank you, everyone, for being here.
Thank you, everyone.